abdominal ultrasound, we tend to forget or tend to ignore. But these are very important. That's why they are called pearls in abdominal radiology. For today's workshop, we have faculty Dr. Prashant Onkar, Associate Professor, NKP SIMS, and Dr. Sandeep Dhote. Both are familiar to you and have done so many workshops in the past. And today's workshop, especially during in vascular malformations, we will try to see the different patterns of vascular malformations, their appearance on Doppler ultrasound, as well as we will in abdominal abdominal ultrasound, we will try to evaluate the less areas, that is the omentum, bowel, adrenals, in, internal hernias, external hernias, indirect hernias, direct hernias, and how to identify and how to interpret. In addition, we will also try to evaluate how to track the undescended testes. So I invite Dr. Prashant Onkar sir to brief you about the today's scientific program. I also invite Dr. Sandeep Dhote to talk about the abdominal radiology, abdominal ultrasound for today's workshop.
Thank you, sir, for the introduction. Today, we, as sir has told, we are trying to cover some not exactly hidden areas, but sometimes ignored areas of ultrasound abdomen, and followed by color Doppler use in various vascular malformations. So we will start with the GIT today. There will be a very small presentation on normal appearance of bowel, then followed by demo of normal bowel as well as various cases. During this testing times of third wave, we have tried to keep the education online, and we have tried to give an overview of various uses of ultrasound and Doppler. And I here thank all my students who always work behind the screen to make this program. I also thank head of the department, Dr. Avinash Dok sir, who is here today with us, and Dean sir, Dr. Kajal Mitra, and the management for giving us this opportunity for keeping the education alive. I also thank Samsung for supporting this as their academic venture since last 10 workshops. So with this, we will just start with normal ultrasound anatomy of bowel. Thank you. Ready? Okay, bowel wall, as you know, contains 5 different layers, and it is quite well demonstrated by convex as well as high resolution high frequency probes. Whenever we measure the various of the bowel, you should measure it perpendicular to the probe to the wall and not as a oblique, so that there is no any erroneous measurement. And various parts of bowel, they have various wall thicknesses, and if you go by books or the literature, stomach should have 3 to 6 millimeter wall thickness, ileum should have 1 to 3 millimeter wall thickness, and colon up 2 millimeter and less. In children, 2 millimeter or more wall thickness should be taken as abnormal. The bowel wall shows alternating hyperechoic and hypoechoic ecotexture. The innermost is the hyperechoic, that is very thin line, that is the border between the fluid and the mucosa. Next hypoechoic layer is the mucosa or lamina propria layer, that because there is muscle it appears hypoechoic. Next hyperechoic line is the submucosa, and followed by a thicker one hypoechoic area or layer, that is a muscular layer, and the outermost layer, that is serosal layer, is the hyperechoic one. So this is the 5 layer. You can see 1, 2, 3 echogenic, and in between there are 2 hypoechoic areas. This is the thicker hypoechoic layer, that is the muscularis layer. This is again lamina propria or muscularis mucosa, and that is serosa, and that is the internal layer. Whenever filled with fluid, you can see it better, and nowadays with good almost major part of the bowel. Esophagus being a thoracic organ, but the esophageal junction can be very well evaluated in what you can acoustic wind. The geo malignancies or lesions are or mass at the gastroesophageal junction or fundic region, and that can be picked up incidentally. So this adds visualize. We cannot visualize fundus properly, but for visualization of body and what we patient 2 glasses of water, wait for 5-10 minutes, and then go settle. We can part of body and the antral region. The pylorus is also very well visualized in most of the patients. So here you see pylorus seen by a high frequency probe. This is a closed pylorus, and this is a open pylorus. You can see the thickness is less than 2 millimeters, as this is a pylorus in case of a child. When the pylorus opens, whenever there is a fluid, you can see the separation of both walls of the bowel, and then again these 5 layers you can see, and on anterior aspect and posterior aspect also. So visualization of all 5 layers, peristalsis, compressibility, these are the features we can very well elucidate on ultrasound, and no other modality can do that. Contrary to the belief that ultrasound is not good for bowel being air containing organs, but if you try to apply techniques, you can certainly get information, and many times surprises they do come while doing ultrasound abdomen in case of various abdominal pains or other symptoms. Duodenum is anterior and superior to the head of pancreas and medial to gallbladder, here, and sometimes air in the duodenum is mistaken for gallbladder calculus. Particularly we find students making that error. That is just due to inexperience, and if you visualize in different views, then you can see the duodenum separately and gallbladder separately. Fluid anywhere, as I said, in the bowel aids in better visualization. So you can give water to the patient. Some people have advocated giving glycol, polyethylene glycol as an negative contrast, but that is practically not used. Then the luminal diameter and peristalsis, as I said, we can easily demonstrate, and we can just do a minimal compression to see that the bowel is getting compressed and there is no plasticity in the wall. The peristalsis is rhythmic and slow. It is seen in small intestine and stomach, and in postprandial state it is more faster. It is rhythmic and slow in the postprandial state, and in fastings it is fast, longer and larger. Sometimes we see retrograde peristalsis, especially in the first part of duodenum and at the IC junction, that is considered normal. Otherwise, retrograde contractions are seen in obstruction, and we can show you some examples in later part of the program. Small intestine diameter more than 25 mm is taken as abnormal, and if you see a dilated loop, just follow it distally, so that to look for any thickening, because thickening at a point that may produce dilatation of the thickening, or sometimes obstruction can produce dilatation of the proximal loop, and that we should look for. Whenever there is a thickening of the bowel, we always look for their extent, their symmetry, and which part of the wall is thickened, and that should be mentioned in your report. In visualization, we can use high frequency linear transducers with gradual, slow and gentle compression. The folds of Kerkering are better seen in a fluid filled lumen. As you see it here, these are jejunal loops having good folds, and that are visualized whenever there is fluid inside. A long strategy has been described for looking for the abdomen. Use region, iliac fossa, come back above from and then hypochondriac to the left iliac fossa. But you can have your own techniques. After doing solid organ evaluation, you can make a checklist and go how to go to see various bowel areas. Cecum, like pylorus, is the most consistent part and can be used as landmark to see the colon and see the terminal ileum and bowel loops in that right iliac fossa. As I said, the negative oral contrast polyethylene glycol has been used to distend 500 ml of polyethylene glycol to the patient. This is the same drug that is used for bowel wash before a colonoscopy, and you get a distended, not distended, but fluid filled small bowel loops very nicely, and then you can evaluate the wall thickness, the peristalsis and other features. This is not playing. Okay. So you can see the fluid fill jejunal. See, these are the fluid filled ileal loops where you see less number of folds. The peristalsis is also slower than the jejunum. Many times patient comes for right iliac fossa pain, evaluate for appendix. There is sometimes tenderness initial. We also feel there is probe tenderness. Though most of the cases the distended all features of appendicitis, it is difficult. So the normal appendix as per literature 30 to 80%, and inflamed appendix is visualized in more than 90%. That becomes a mainstay in diagnosing acute in most of the patients. Normal appendix measures than 6 mm in diameter. Again, the wall thickness is less than 2 mm. So this is the normal appendix coming from the this cecum. If appendix is not seen at this place, you can just make position, so go downwards and try to see the retrocecal appendix. There are many studies who advocate this technique for visualization. Make the air in the cecum fall off your field so that you see that retrocecal appendix very nicely. So when linear probes were not that good, we used to diagnose acute appendicitis by using convex probes. As seen here, this is a distended appendix, and same it is better seen on a high resolution ultrasound. So the suspicion and your vision in that area should be intensified whenever there is right iliac fossa pain. Ascending and transverse colon, we can just see in the transverse section a sigmoid. You can look in the left iliac fossa. While the hepatic fixture is very commonly or easily seen, fixture is little up. So sometimes for the other side, and just ask him to take his bow his head and may try to see the splenic fixture if it is not visualized in regular supine or decubitus views. Haustra may be seen And sometimes rectal diameter measurements is required in assessment of children with chronic constipation. The pediatrician asks for whether the rectum is dilated. So this is how the haustra appear. And whenever there is fluid in the colon, you can see them better. Haustra. Once you finish the bowel assessment, we can just look for free fluid. In the presence of free fluid, we all know the dependent parts of the abdomen are the pelvis and the Morrison's or the hepatorenal pouch. Ultrasound is quite sensitive, and these collections can be easily visualized. Even the smallest amount can be seen. Though in females, if you see minimal amount of fluid, just correlate, sometimes it is a physiological fluid in between the menstrual periods or in the ovulatory phase. The collection of fluid in the peritoneal spaces is also seen. Sometimes it is all around the abdominal organs, or sometimes you see the fluid in between the bowel loops. Next area is the mesentery. Mesentery scanning oblique from fossa, and it appears as a series of elongated structures. They are separated from each other by echos that represent the peritoneal surfaces of the mesentery, and there is echogenic fat and it is said that the fat should cover less than half the circumference of and the mesentery should cover less than half the circumference of a bowel loop. And you see many a times nodes in the mesentery. They are more commonly seen in children, and many a times children come with abdominal pain, and you see multiple nodes. The mesenteric nodes have a shape ecosimilar to hypoeconomicity, and even smaller. So that mention size, maximum size we each of 8 mm is taken as upper limit of normal, and in adults more than 15 mm is taken as abnormal. Sorry. Adrenal adrenal evaluation is a bit difficult. Overlying to rib cage and the adjacent organs. The high resolution ultrasound, we can identify the adrenals at the upper pole of the kidney. Left side adrenal is sometimes more difficult to see, but in children you can see very nicely. You see the adrenals, and it should include your routine examination protocol. It is slightly echogenic to the than the retroperitoneal fat, and but the medulla appears little bit more echogenic. The differential diagnosis for adrenals in form of lymph nodes, bowel loops, upper pole renal masses, spleenules, pancreatic and splenic lobulations, and so on and so forth. The newborns have bigger and echogenic and more homogeneous adrenal glands, and the size is said to be proportional to the gestational age in a premature age. In adults, their limbs can measure up to 4 to 6 centimeter in length, 2 to 3 centimeter wide, and it's quite thinner, so it's 0.2 to 0.6 centimeter in thickness. So adrenal evaluation is definitely required. So coming to checklist of bowel, identify the esophagogastric Identify pylorus, look for wall thickness, peristalsis and length. We know how to distend the stomach by giving 2 to 3 glasses of water. For evaluate, look for this appendix thickness, compressibility. Look for ileocecal junction, then colon, wall thickness, lumen and diameter. There are 3-4 common things whenever you see any part of GIT except for esophagogastric junction. That is the thickness, peristalsis, lumen, diameter and of small bowel. While evaluating mesentery, again wall thickness, lymph node size, texture, that you should look for. Again, omentum, normally it may not be seen, but it is whenever there is a disease, we can see a thickened omentum. And finally, you should look for the fluid. That's how you proceed for bowel demo of normal ultrasound, followed by some cases that we have. Thank you.